Yes, sir.
Yeah,
Sir,
First
we
of
are
all,
able to hear and see
yeah,
you. Please.
yeah. First of all, thank you very much, the organizers of APNSA, for inviting me to chair this session, participate in the conference. It's a great meeting on a virtual platform. And I'm very happy to be in this Brain and Spine Society orations. And I'm particularly happy to listen and chair the session of my close friend, Dr. P. N. Shailaja. You see, leave alone the formal CV and all, I know something about her, which probably many people don't know. Everybody knows that she's a professor in Chitra, and she's in charge of she actually established this stroke center. Everybody knows that, and she has multiple publications. But I want to say two things about Shailaja. One is that Shailaja is one person who has always followed her heart. Many of you don't know that she was initially in the subspecialty of epilepsy because Dr. Radhakrishna was an epileptologist and he had made Shri Chitra into a epilepsy center of international repute actually. And anybody who would join that place would be an epileptologist. But he also realized that sometime that somebody needs to take up stroke. And for that, he invited Shailaja, and I was there in the interview, and she did extremely well. And she changed because even though she was in epilepsy, but after a few years, she changed over to stroke. I think very few people will have courage and guts and the inclination to do that. So, and that was the loss for epilepsy was the gain for stroke. So, and in stroke, she has done extremely well, which her CV is showing, which is come here. She went to Calgary. She did a stroke fellowship there. She worked very hard in the Indian Stroke Association and rose to the level of the president, one of the most effective presidents of Indian Stroke Association. And she was also a clinical professor in UK. And has been a technical consultant of Government of India for many stroke care activities. She has arranged a lot of meetings, not only for doctors, but for rehab workers, for nurses. She's a member of the task force of ICMR. And there are a lot of things. And in fact, we did one Indo-US collaborative project with Harvard University, and Shailja was part of that. And I think she published the maximum number of papers out of it, which actually highlights the stroke peculiarities of this country. So really, I'm an A-class person, researcher. But the second thing which I want to tell about Shailaja, which again many people may not be knowing, is that she is one of the very few people who, in spite of having a lucrative private practice, went back into the academic field. I have always seen people from academics after certain years going into practice, but this reverse flow, I think Shailaja is probably the only one, or maybe one or more persons. And really, I mean, this is amazing. And then after she joined uh, the academic stream, I think she is only going high and high and high. So I often say that what PT Usha was to the world of sports in India, PN Shailaja is to the world of stroke. Shailaja, it's a unique pleasure for me to be the chairperson of today's session. And one more thing about Shailaja is that she has special interests, and her special interest. Uh, these are actually special interests of research. Otherwise, as neurologists, we see everything all the time, but she focuses. I know when she was focused on TIA, and she did excellent work on TIA, published in Neurology Journal, and then there was a intracranial atherosclerosis, excellent work, and then neuro rehab, excellent work, and then Moya, excellent work. And I think for the last few years, her research is focused on stroke imaging, vessel wall imaging. Uh, so it is a pleasure to hear Shailaja today on the latest radiological techniques and implications in stroke. Dr. Shailaja, please.
Thank you, sir. That is too much, sir. I really thank you for this kind introduction. And sir has always been a real motivation for us in the not only in the Indian Stroke Association as a part. I think we all look upon sir to really learn from him. And sir has always been a very close friend and to whom we ask for advices even in difficult situations. You remember those situations very well, sir. So thank you, sir, and thanks to the organizing committee and Dr. Venkat Raju for giving me this opportunity to give this talk today. My talk is for 20 minutes, so hence I thought I'll confine my talk to ischemic stroke alone and not go into hemorrhagic stroke, because otherwise it will not be easy to discuss on both together. I'll now share the screen. So hope you can see my screen. My screen is visible?
Yes, ma'am. Yes, yes, please.
So coming to neuroimaging in acute stroke, we know that we do an imaging in acute stroke mostly to exclude a bleed. We try to differentiate between the stroke mimics, and most important in acute stroke is try to decide which are the candidates for intravenous thrombolysis or endovascular treatment. And for this, now we have got a lot of advances in the neuroimaging, and which has made a big impact in very carefully selecting the patients who are likely to have the best outcome, and also to prognosticate and counsel the family regarding what is the best outcome you can expect from these patients. So we know about the stroke mimics, the usual subdural hematomas from ICSOL. We look for the bleeds, what is the type of bleed, lobar versus bilateral versus, even look carefully for any bleeds in the sulcal, which can be missed if you do not carefully look at the scan. And what is most important in acute ischemic stroke are the 4 P's we are all familiar with. I will briefly go through each one of them. First is to look at the parenchyma to assess the early signs of ischemia, if it is an ischemic stroke, and rule out a bleed. And we need to now, vascular imaging has become very important, because vascular imaging is the way in which you look at whether there is a major vessel occlusion to make your decision of recanalization therapy, revascularization therapies. And not only that, we need to look at the etiology by finding out whether there is any stenosis or a partially occlusive thrombus, or whether there is any disease in the intra or extracranial circulation. And then comes the perfusion imaging and identifying the penumbra, which is relevant to situations where you have patients who come out of the time window, or in patients who are coming as a wake-up stroke, or the time not known, where you need to know how much of penumbra is left to decide on the treatment. I'm not going into the details of aspects. We know that aspects is the best way to identify the early signs of ischemia, and we know it is for anterior circulation. We take off 1 point each depending upon the early ischemic changes. And what is important is to look at the cutoff of the aspects. If you have a 8 to 10, that means the patient is having a very small core. If it is 6 to 7, it is a moderate core. And why it is important is that if you have a score of 4 or less, it is unlikely that you are going to take these patients for IVT or for endovascular treatment. And the best patients are who come with an aspects of 8 to 10. And in the intravenous thrombolysis, have clearly shown aspects is going to make a very important role in deciding on the outcome. If you have an aspects of 8 to 10, they do very well. And the same is relevant for intra-arterial therapy. This is actually for one of our fellows itself who presented, who looked into the data of aspects and looking into its correlation with the outcome and the intracerebral hemorrhage. You can see 8 to 10, you see the outcome for MRS up to 2, even up to 3, the outcome is more than 50%. But when it comes to an aspects of 0 to 4, you see the mortality is around 55%. So it also shows that when you have an aspects of 0 to 4, your bleed risk after a thrombolytic therapy, or even if it is an endovascular treatment, is significantly bad, and you are likely to have more patients with bleed as a symptomatic intracerebral bleed. There is also a posterior circulation aspects, which we are not using because CT is not a good imaging for posterior circulation. But if this is an aspect scoring system which was developed by the Calgary team, and we were all doing our fellowship, but this can be used in selected situations when you do not have an access for MRI, and this is relevant for basilar occlusion. But more important is that you need to do it only for, use it only for the images where you have the source images, and you look carefully at the source image to identify the damage. Currently, it is very clear that for ischemic stroke, we need to do a CT angiography or an MR angiography and look at the vessels and make your decision of treatment. What is most important is to look at the vessel occlusion, look at the infarct, then clot assessment and collaterals. Now, collaterals has taken an upper hand with regard to making a decision of thrombolytic therapy, not the vessel occlusion alone. Vessel occlusion is very, very important. Where exactly the vessel is occluded is going to make your decision of whether you go directly for intravenous treatment alone, or you go for a bridging versus endovascular treatment. So if you have a carotid T occlusion where the thrombus is here in the proximal region, or if there is an L occlusion or in the M1, you know that these patients would require bridging or direct endovascular treatment. But if it is an M2 occlusion, these patients are candidates who can go for IVT alone. And it is also important to measure this length of the thrombus. You can see here the length of the thrombus can be measured here. Here it is only 2 millimeters. So what does it suggest? You have a patient with a major vessel occlusion. If it is a short thrombus, these patients are likely to open up with intravenous thrombolysis alone. And if you have a big clot and the clot length is more than 8 to 10, you know that these patients are unlikely to benefit with IV thrombolysis alone. And clot burden score is another thing. Don't think it is very difficult to look at the clot burden score. You just see how big is the thrombus. Is the thrombus extending from the ICA to the M1 and all the branches, or if it is confined to one short segment? By looking at the thrombus, you know if a patient's clot burden score, that is at 10 means the clot is not there. If you have a clot in the M1 alone and rest of the retrograde filling is very good, then you know that the clot burden is high, and these are the patients who are likely to benefit better. But if there is a big clot involving the whole region with a clot burden of 0, even with endovascular treatment, they are not unlikely to do very well. But one point we need to understand is with the recent scanners, that is, if you have a 256 light scanner or the fast scanners, please don't look at the source image and make your decision of the infarct code. This is from one of our papers where we looked at the source images and compared it with the final volume of the infarct. And you can see here, this is one of our patients, the non-contrast CT, the aspects is around 8, very subtle changes. But if you look at the source image, the whole area, this area looks like the core. The CTS source image aspects was 5. We opened up the vessels and you find that the infarct core is not big. So in the source images, if you look at, most of the time, the source image includes a penumbra also. This is because it is, if it is a slow contrast flowing, it is more of the time it is a volume weighted, and the other one it is the flow related. So when you have a fast scan, it's always important to look only at the non-contrast CT to make your decision of looking at the core rather than the source images, because it includes the penumbra also. So coming to the collaterals, currently it's mandatory that you look at the collaterals if you do a CT angiography and then decide whether this patient is an ideal candidate. But that should not be taking a patient away from the decision of EVT or IVT, but it will help you in prognosticating the patient. You have a patient with an aspects of 5 or 4 to 5 coming in at 16 hours, and you find that the patient's core is like this. You have to be very careful in making your treatment because the outcome is not going to be that good. This is a modified TAN system. We are using the TAN system, whereby you can classify them into poor collaterals. So how do you say? You can see the leptomeningeal collaterals on this side. There is not much of collaterals. Here we can see it is almost similar, suggesting that the collaterals are good. You can also use the MITIF system. MITIF system is, you can look at how the vessels are. Here you can see only the distal cortical superficial branches are filling. But here you can see the filling into the Sylvian fissure also. Here it is close up to the thrombus. So this is the good collaterals. This is the intermediate and this is the poor collaterals. Now there is the multiphasic CTA. This is an advancement in the fast scanners. If you do the fast scanner a single phase CTA, sometimes you can misinterpret your collaterals, and sometimes a good collaterals can even look like a poor collaterals. So it is always better that you do a multiphasic CTA, and this will give a better idea regarding the collaterals. And the software, it is an automatic image reconstruction is done, and you get the information within 2 to 3 minutes. It is not really important for the collateral assessment in the acute stroke. It is also useful in making your decision on prognosticating the patient even in the subacute phase. This is one of our data from a symptomatic. So this is a patient who have been 2 weeks after the stroke, where the patients are having cervical internal carotid artery occlusion. We looked at how the collaterals were helpful in making a decision of outcome of these patients with regard to correlating the collaterals with the baseline stroke severity and also the 3-month outcome. We looked at the leptomeningeal collaterals, the anterior communicating artery and the posterior. We looked at both the primary and the secondary collaterals. And we graded them into grade 1 to 5. This is, you are not seeing any collateral anterior communicating artery at all. This is doubtful. Here you can see a hairline. This is definitely present and this is robust. Similarly, we did a grading of the posterior communicating also. And here we can see that when the collaterals were pure, this is 0 collaterals, collaterals 1, and this is more than 2 collaterals. You see that when the collaterals are more, the patient's NIHS, baseline NIHS was less, and also the 3-month outcome. So it is always worthwhile looking at these collaterals even in the patients who are having occlusions even in the second phase. In 2019, the AHA guideline has come out that acute ischemic stroke, it is always important to incorporate the collateral flow status also into your clinical decision making, especially in those borderline patients or the late time window patients when you are giving a very expensive treatment, which is very relevant in the Indian scenario. It is currently the thrombus permeability has come up in a big way. This is very easy to look at when you do the CT angiogram, if you look at the source images, and you can just grade them. There is a grading, it's like 0, 1, and 2. What you look at, can you see there's a M1 occlusion, but you are not seeing any contrast at all. This is a situation that is very bad where the contrast permeability is not there at all. Here we can see the grade 1, you can see there is a contrast permeating diffusely through the thrombus. And here you can see a hairline flow too. This is very easily, within minutes you can assess this. The importance is that if you have a grade like this, these are unlikely to open up very well with IV thrombolysis. When you have a permeable thrombus, that gives the TPA to have more surface to act, and this is likely to open up even not only with IV TPA and also with endovascular treatment, they respond better. So what is important for acute ischemic stroke thrombolysis decision making is look at the non-contrast CT, look at whether there is an occlusion, how big is the thrombus, and you look at the collaterals, and that is more than enough in making the decision of thrombolytic treatment. All the endovascular trials have used the same CT-CTA, and only in the SIFT prime and extend IA, CTP was used for when the patients are coming within the first 6 hours. There is no need to do any perfusion studies. We can make all of our decisions with the CT-CT angiogram, and especially in the later time in your patients to look at the collaterals and make your decision of treating these patients. This is just one of our patients with a 64-year-old, came at 4 hours, NIHS 20, very bad stroke. And this is actually the opposite side ICA is already chronically occluded. Here you see the ICA is occluded from the origin, and you can see this is a bad stroke to have. And this is the collaterals, multiphasic CTA. You find the collaterals are good in this patient. We went and did a stenting here and opened up the vessels, and we could see that only that core part, which was initially infarctus, was infarcted, and this patient did well. So if you have a good collateral, even a big clot burden, if you are able to open up, the patient is likely to do well. So coming to CT perfusion, when do you do CT perfusion? CT perfusion currently is required only in situations where the patient is a wake-up stroke, or in situations when the time of onset is not known, or when the patient is coming after 6 hours, when you need to know how much of penumbra is left. You can do a CT perfusion study, or you can do an MR diffusion perfusion mismatch and make your decision of treating and look at how much of penumbra is left. We have got now clear protocols of how to decide on the CT perfusion pattern and look at the penumbra. You look at the MTT and see whether how much the Tmax, if it is more than 6 seconds, and you look at the CBV, CBF mismatch. This is one of a patient who had a favorable CTP pattern. It is a patient who is a wake-up stroke, very good scan with the M1 occlusion, good collaterals. You can see that there is a CBV, CBF mismatch. This is a very small core. You are seeing a big penumbra, and this patient underwent mechanical thrombectomy with a very good outcome. But sometimes even in the time window if the patient comes in, you may still find that the patient does not have much of a penumbra, and these patients are unlikely to do well even if you treat these patients with mechanical thrombectomy. How low you can go with regard to the core pattern, whatever is given is there should be a mismatch of, if you look at the infarct core and the perfusion penumbral mismatch tissue of more than 1.2 and a Tmax of more than 6 seconds, and we should have this in these patients, then taking up these patients for mechanical thrombectomy is useful. The 2018 guideline came up with that perfusion studies are not required if the patient is coming within the 6 hours, and in the late time window, we need to do perfusion studies in these patients. So coming to What are the advances which has come up in minor stroke and TIA? We know that TIA and minor stroke is an emergency because all these patients are likely to come up with a big stroke, and about 5 to 15% of them can have a stroke in the first 3 months. So TIA is a medical emergency. So what are the information you get by imaging these patients? You do a vascular imaging. We can look at whether there is a carotid stenosis, whether it is an ulcerative tract. You can look for intracranial stenosis. You can look at MRI, because MRI is the one which is very useful in minor strokes and TIA, because parenchymal CT imaging is more than 80 to 90% of the time normal. And you can look at the diffusion of the varying ages. That means if there is a um, subacute infarct or whether it is an acute infarct at the same time. You can look at single versus multiple DWA. When multiple DWAs are there, they are at higher risk. And you can also look at the infarct pattern. All these are going to help you. Infarct pattern is very relevant to intracranial atherosclerotic disease. You look at the patterns, that the pattern will help you to prognosticate regarding the future stroke risk, because if your patient has got a branch atheromatous disease as seen by the infarct pattern or a hemodynamic pattern, they are at more future risk of having future ischemic events even on best medical treatment in intracranial atherosclerotic disease. So imaging will have a good prediction of the future risk and also prognosticating patients with TIA and minor stroke. I will just briefly talk about the MR vessel wall imaging. MR vessel wall imaging has come up in a big way now. It is very useful in both MR vessel wall imaging in intracranial vasculopathic processes, and also it is very useful even in plaque imaging in extracranial atherosclerotic disease. In MR vessel wall imaging is an imaging which is usually done in the 3 Tesla MRI, and there are specific sequences which are done. This actually looks at the imaging of the vessel wall, which will help us to characterize the pathophysiological process which is involved, and thereby helps in the etiological subtyping of the stroke. In intracranial atherosclerotic disease, we know that you find an eccentric plaque, and you can look for so what we are trying to image is the fibrous cap and the lipid core, and also you give contrast imaging and you look at whether there is any enhancement. This is one of our patients who had a stroke of left MCA territory. There is a 50% stenosis of the MCA. You want to know whether there is an intracranial atherosclerotic disease, or is it a vasculitis, or whether it is a partially occlusive thrombus. You see an infarct, a cortical infarct, multiple infarcts are seen. And a T2, if you look at it, if you see a T2 hyperintensity in the hypointensity, this is a very helpful image. And if you see a contrast enhancement there, in fact, you can make out that it is a part of an intracranial atherosclerosis. So this is a very important sequence which is going to help you to differentiate between intracranial atherosclerotic disease, and it will be eccentric. Coming to CNS vasculitis, we know that all the patients meningocortical biopsy may not be possible, and some meningocortical biopsy can be negative in about 40 to 50% of these patients, and hence MR vessel wall imaging will be an additional tool. It is not a confirmatory investigation. It will help as an additional supportive investigation in the evaluation and confirmation of your diagnosis. So in CNS vasculitis, you see a concentric vessel wall thickening, and it will be diffuse. It may not be involving one vessel, it will be involving multiple vessels, and it is also helpful in following up or monitoring the patients for their treatment too. So this is one of our patients with a CNS vasculitis. This patient came with a rapidly progressive stroke with a language disturbance, going on to akinetic mutism and seizures. There is a infarct, and also there is a macrobleed. There are some microbleeds, significant grade 3 small vessel ischemic changes. So recurrent stroke in this picture, we strongly suspect the possibility of a CNS vasculitis. DSA showed the classical beaded appearance. You can see the aneurysmal dilatation with stenosis in many of the vessels, suggesting the possibility of a CNS vasculitis. And the CSF was also abnormal in this patient. And this patient, this is a MR vessel wall imaging. Can you see that all these, you can see in the basilar, in the vertebral artery, and also here also you can see there is a enhancement of these vessels with thickening. So here you see concentric thickening rather than eccentric. Very rarely eccentric can be seen, but most of the time it will be involving not one vessel, multiple vessels. And this patient is on our follow with aggressive medical treatment, and this patient had an MRS of 3 and 6 months. Now the patient has already completed 2 years. So high resolution vessel wall imaging, this we recently published our vessel wall imaging data in Neurology India. So this is a sequence which we use, and these are the parameters by which you decide to differentiate between each of the high resolution vessel wall imaging will help in differentiation. And this is one data which we have published. We looked at our high resolution vessel wall imaging done in our patients and looked at how it was useful in our decision making for decision making with regard to the etiology. And in ICAD and in vasculitis, we found that it is very useful in the sense that we could make out these eccentric vessel wall thickening, and also the vasculitis patients, we could confirm the diagnosis. It's not a confirmation, it will be an additional supportive diagnosis to make your diagnosis of vasculitis in these patients. Currently, MR carotid plaque imaging has come up, and this currently it is the plaque imaging. We know that how it is going to be helpful is in situations where a patient is having an asymptomatic stenosis. You want to decide whether it is still a high risk plaque where you want to make your decision of treating. Maybe in a borderline 50% stenosis where you want to still decide whether it is a high risk plaque or a very smooth plaque. MR carotid plaque imaging. Now, even without contrast, you can look at the diffusion imaging, and there are a lot of data available on MR diffusion weighted imaging and looking at whether, and it has been correlated very well with the histopathological features, which we have also done, and we are just writing up that paper, where we have looked at the high risk plaque features can be made out even without contrast by the carotid plaque imaging. So, where we can make out the vulnerable plaque, the intraplaque hemorrhage, and whether there is a fibrous cap rupture. So to conclude, non-contrast CT and CT angiography is enough in the decision making for intravenous thrombolysis and endovascular treatment in acute ischemic stroke in the first 6 hours. Advanced imaging like CTP and MR perfusion needs to be done in situations where the patient comes in the late time window or where the time of onset is not known. I would say that collateral assessment is a very important parameter we need to look at in the after CT angiography to make your decision on prognosticating these patients when we are giving expensive treatment. And MR vessel wall imaging and also carotid plaque imaging has become as a very important tool in etiological subtyping and treatment decisions in patients with stroke. Thank you.
Thank you, Dr. Sylaja, for a very, very comprehensive lecture and summarizing all the latest advances along with your own research. If there's any question from the audience, they can ask. In the meantime, I have one question, Sylaja, for you. In fact, it's a doubt which I always had about the collaterals. The guidelines say that collaterals help us to make a decision. But my point is that if we see a small core, either on diffusion or on CT perfusion, let us say after 12 hours or 14 hours, doesn't it automatically mean that the patient has good collaterals?
Yes,
so in a situation where a patient has a small core, I mean, it's unlikely that he will have poor collaterals. And even if he has poor collaterals for some reason, still we are going to intervene. So shouldn't we look only at the core rather than worrying too much about collaterals? Please clarify this for me.
So I think it's a very, very good question. What I would say is, as sir has mentioned, if the patient has got a small core at 16 to 18 hours, invariably it is telling that the patient has got a good collateral. There is no doubt about it. That has been shown from the late window studies of the dawn and the diffuse, has clearly shown that the collaterals are the one which made the core to be small. So if a patient is having at 16 hours a small core and there is a major vessel occlusion, you don't have to look at the collaterals. I totally agree with that, because invariably the collaterals are going to be good. But I would also, as sir has mentioned, that it is, if that same patient is having a poor collateral, I would still go ahead and take up this patient. Yeah. But only point I want to highlight is that it is useful in situations when there is a big clot burden and you have a borderline aspect patient, And if the collaterals are poor, whenever we have intervened, we have also landed into problems, because these are the patients where even during the time of the procedure of that 1 hour, you are going to have a patient where, so these are the patients in that late window, that paradox, that diffuse dawn data or the diffuse 2 data, if you look at, you find that within the 6-hour patient, these are the patients who came in the period where the infarct core is big. So invariably in those patients, definitely it is going to make our decision, because we are going to spend 2.5 to 3 lakhs, and whether it is worth spending, especially in a patient who comes in a borderline time and the aspects is poor. And also I would say it also helps in a patient, young patient who is a 45-year-old, comes to you as 24 hours, aspects is 4, as you have mentioned, sir, and the patient has got a good collateral, this patient is still likely to do well. So
even though aspect is 4.
Aspects is 4. So that is what they showed in their data too, sir. If you look at that escape data, the MR clean data also, which they showed the collaterals, the patients who are having that borderline aspects, it is better to take up when they have a good collateral.
So
But
even if it's,
there may be cases either way.
Sylaja, one more thing from your experience, I want to know that one of the things which makes us very afraid is this post-procedural bleed, bleeding complication. What is your experience, and are there any predictors of bleeding following reperfusion bleeds? Is that an issue or not much?
Yeah, yes, we have seen, sir, but we have seen very less, because maybe we are also a bit super selective in selecting our patients too for the studies, because ours is 50% of patients are poor patients. So when their scan is not really good, and we are not sometimes very aggressive, but we also definitely see a lot of reperfusion injuries. But the reperfusion injury of HI1 and HI2 patients, sir, they are all they do very well. And their outcome is relatively good. As I mentioned, if the patient is having a PH1 or PH2, definitely their outcome is not good.
And the last question, Sylaja, you are very actively involved in vessel wall black blood imaging. What I want to know is that you said that it is almost suggestive, but it is not. You cannot depend 100% on it. So would you please dilate on that?
Okay. Now, for example, sir, I would say because the confirmation for CNS vasculitis only, I'm telling that. In ICAD, it is very useful by vessel wall imaging. You can say it is ICAD and it is not a partially occlusive thrombus, because the imaging is very helpful in differentiating between a partially occlusive thrombus versus an ICAD. What I told it's not very helpful is in CNS vasculitis, because that cannot be used as a confirmation of CNS vasculitis, because confirmation is always a biopsy. But if you have a patient with a clinical spectrum fitting in with a CNS vasculitis, and you have a DSA showing a picture of a classical beaded appearance, definitely, ideally, you need to do a biopsy, and the biopsy comes as negative, or the patient is not willing for a biopsy. I would use MR vessel wall imaging to support the diagnosis of CNS vasculitis.
Thank you, Sylaja. Thank you very much for that brilliant lecture. I don't see any questions here, but I think I have asked questions on behalf of the audience and participants. Thanks a lot, and I hand over to. I thank my co-chair. I thank Sylaja. I thank all the participants, and I hand over the session to the organizers.
Thank you, sir. Thank you, ma'am, for your excellent talk.
Thank you, sir. Thank you, Call, sir. Thank you, the organizing team. And thanks to all for giving me this opportunity.
Thank you, sir, and thank you, madam. And next session will join for Swims Award papers.